And I would quickly go through this very important topic in soft tissue sarcomas, and that is pre-treatment re-excision. As we all know, soft tissue sarcomas in children, we have divided them into rhabdomyosarcomas, which behave in a different manner. And then we have the non-rhabdo soft tissue sarcomas, also known as NRSTS. And most of the RMS children who present with RMS, they are less than 5 years of age, whereas the children who present with non-rhabdo soft tissue sarcomas are usually in the adolescent age groups, 15 to 19 years. And surgery is the prime treatment modality of all pediatric soft tissue sarcomas, for that matter, even for adult sarcomas. While in RMS, chemotherapy has a major role, in non-rhabdo soft tissue sarcomas, it has a limited role. So again, surgery becomes much more important. Of course, we have the adjunct of radiation therapy, and we'll be listening to Dr. Lesker soon after this with a lot of detail. So what is important is that the message about the possibility of a rhabdomyosarcoma or a NRSTS should always be considered whenever we are resecting a soft tissue mass in children. However innocuous it may look like, but we must always keep that in mind. So it is always good to either do a needle or a core needle or an incision biopsy, and then followed by a planned wide local excision with negative microscopic margins. So that we don't get into a situation like what Dr. Sajid calls oops surgery. So just quickly a recap of the risk stratification, because it's important why we should do PRE. And so we'll just recall, we know the low, intermediate, and high risk groups of IRS. And we have the stages 1, 2, 3, 4 based on the favorable, unfavorable sites and the size less than or more than 5 centimeters. And now comes the clinical group. Now, this is very, very important, and it is based on the upfront resectability of the tumor. So we have a clinical group 1, that means it's completely resected and the margins are negative. And here, if it is an embryonal rhabdomyosarcoma and clinical group 1, we don't need to give radiation in most of the cases. So as you can see here, the dose of radiation and actually the radiation itself can be eliminated if we have a microscopic negative margin and clinical group 1, that is upfront surgery. Even in other groups, we can decrease the dose of radiation if we are able to do a good surgery. So clinical group 1 and 2 both have a lower dose of radiation. And when we're dealing especially with smaller children, sometimes radiation can be a challenge because there are a lot of long-term side effects. Of course, I know the team at Tata and many other teams all over the world, they do not take it as a challenge anymore. But yet there are many more centers who do face a problem with giving radiation to a small child. And it also may be a crucial area. So unplanned resection of a soft tissue sarcoma outside an oncology setup often necessitates the need for a wide re-excision. And these patients may have some delay in achieving complete resection. And this could also lead to an increase in the local recurrence time. And it's also believed that an unplanned resection may lead to breach of tumor margins, tumor spillage, hematoma formation, and local dissemination of tumor. So all of these may be associated with local recurrence. So to the extent possible, it should be avoided. But if you get a patient, we often get patients who had these unplanned resections outside, and now the biopsy has come as RMS or a synovial sarcoma. And then they come to the oncology care center. So the answer is that we must always, wherever feasible, we must do a pre-treatment re-excision or a PRE, what is known as. So I just thought I'll quickly go through this very nice article, and it's by Professor Chui himself from St. Jude way back in 2002. So they analyzed 116 patients, children who underwent primary re-excision or pre-treatment re-excision for non-rhabdo soft tissue sarcomas. Of these, a majority of them were unplanned resections. And these were actually incision biopsies, which turned out to be sarcoma, and then they were referred to the higher center. So Out of these 94 unplanned resections, 69 patients were feasible to undergo a PRE. And here you can see 60 out of 69. That's a very good percentage. They were able to achieve IRS group 1, that is negative microscopic margins. And the remaining 9 were group 2. And of course, where it was not feasible, they were taken as microscopic margin positive and they were group 2. And we look at the characteristics of these 69 patients who underwent PRE. As expected, it's NRSTS, so the age group is much higher, around 12 years. And the most common diagnosis was synovial sarcoma, followed by malignant fibrous histiocytoma and fibrosarcoma. Primary location, 70% was in the extremities, and more than almost 80%, the size was less than 5 centimeters. And that is why probably upfront surgery was possible. Now, what is most important in this is that almost 50% of these patients had presence of tumor in the PRE specimen. So that is very, very significant. So we should never hesitate to do a pre-treatment re-excision. And whenever we have, the other thing is that we were able to achieve almost close to 90% patients in the IRS group 1, clinical group 1. So then the radiation was also avoided in most of these patients. See, 66% patients did not require radiation. And the estimated 5-year survival, event-free survival, and overall survival rates were excellent, 98.3% for these 2 patients. So the authors concluded that pre-treatment re-excision should be performed whenever feasible in pediatric patients with non-rhabdo soft tissue sarcomas. In fact, even for rhabdomyosarcomas, those who had initial unplanned resection. And there is a significant proportion of patients who have residual tumors, and a negative microscopic margin can be achieved in a very good proportion of patients, and hence we can downstage the tumors and we can avoid radiation. So I just thought I'll quickly share a couple of cases within the limited time. This was a 14-year-old boy. If you can see, he did not undergo any imaging. He had a soft tissue lesion over here. This is the back, this is the cranial, and this is the caudal end. And somebody did an excision, and the biopsy came as synovial sarcoma. So we did not have any details of the operative imaging. There was no preoperative imaging available, and we did not have much details of the operative notes as well. So definitely we thought of taking him up for a PRE. So I will quickly show one short video within the limited time, and I'll move it forward so that we can finish it in time. So here we have marked the scar, so it's important to excise the scar. And the patient is in prone position, and that's the right side paraspinal region transverse scar. So we're marking the incision with a margin on the skin itself. And it's important to go deep enough. So imaging was done, MRI was done, and there was no obvious residual tumor on the imaging, except for some post-operative changes. He had come to us about 3 weeks after the previous surgery. So it's important, as in all sarcomas, whenever we're doing surgery for sarcomas, that we should not visualize the tumor or the scar area. We should try and go as wide as possible within the circumstances and the location of the tumor without causing too much of a deformity. And so here we went right up to the paraspinal muscles, because the muscles were not involved on the imaging, and they seem to be free. And because the size of the tumor was close to 5 centimeter, looking at the incision size itself, sorry. So we decided to put brachytherapy wires at the same sitting after doing the PRE. So this is a tumor bed. And then this is the marking being done for placement of the brachytherapy wires. And then one by one, with the help of the radiation oncologist who comes inside the OT, and the brachytherapy wires were placed. And then they were sutured, and the ends, the buttons were placed, and then the excess was cut. And after placement of all the brachytherapy wires, we closed the wound in 2 layers. And also the wires were sutured to the tumor bed, the excision bed. And this was closed over a drain. So he completed his brachytherapy, and after which, this is the excised specimen. This is after, at the end of the brachytherapy closure, and the wound healed very nicely. Unfortunately, he developed, we decided to give him chemotherapy as well. The specimen did show some residual microscopic tumor, and so we decided to give him chemotherapy as well. And because the size was more than 5 centimeters, and he developed a radiation recall after that, and so we had to stop chemotherapy, but he's done well. Another 4-year-old boy, he had a small soft tissue lesion near the ear, external ear pinna. And somebody excised it, and that came as rhabdomyosarcoma. So when he came to us, he just had this little scar. And the parents were very anxious, obviously, because it was the ear, and it's, the appearance of the child matters a lot. And all the imaging, including PET CT and everything, was done, and there was no evidence of any residual tumor anywhere. But we had to do a primary re-excision. The skin did not seem to be involved posteriorly. We did an ultrasound as well with a small probe. So we just decided to do a primary re-excision and do a frozen section. So we just excised the entire cartilage and just left the posterior skin behind. And this was the primary closure. So the frozen section came as negative margins, but however, the confirmatory histopathology turned out to be positive, although we could not visualize or we could not do any imaging and find any tumor anywhere. So although the wound had healed very nicely, beautifully, you can't even make out the surgery was done. We planned for a much wider excision, and this time full thickness. Along with the cartilage, we excised the entire full thickness of the tumor. Again, sent for frozen section, and that came as negative. That's a specimen. And then, with the help of our plastic surgeons, we took a graft, full thickness skin graft, from posterior auricular area of the opposite ear and fixed it here. And this end of the excised pinna we sutured here. So this was the base, the base where we fixed the full thickness graft. And it healed quite nicely, except that his ear was a little bit bent posteriorly, and that they said that we could do a revision surgery later and correct it if he wanted. And so we were able to avoid radiation in this small child, and he has also done quite well, and he's completed his chemotherapy. So thank you so much for your time, and I'll be happy to take any questions.